Hello, everyone, and welcome to today's Tuesday topic. Today's topic is finding our interprofessional voices, collaborative conversations with our friends from the CNHP Simulation Committee. So today we have Dr. Kate Morris, who is the Assistant Dean for Experiential Learning and Innovation and Associate Professor of Nursing. And joining her today is Dana C. Farbaugh, MD, Associate Dean of Clinical Education and Professor of Obstetrics and Gynecology. Thank you. Yep. Sorry. All right. Kate, take it away.
All right. Awesome. Thank you. Well, hi, Carol Ann. We're happy you're here. So Carol Ann, we'd love for this to be more of a conversation. We will check in with you frequently. I'm going to put up our slides so that when we have our recording, we're also representing our colleagues, Megan Shattuck from undergraduate nursing and Genevieve Pareca from undergraduate nursing in the Sim Lab, who were both unable to join us today. So it was a collective project, and we should also have our SimOps team in there because they were critically important to us being able to figure this all out. So unfortunately, nobody else pays us any money and we have no conflicts of interest. So what we hope to achieve today was to talk about some of the barriers for faculty to engage in interprofessional education, some of the benefits, and then think about with Dana here some of the opportunities that we have between CNHP and the College of Medicine, and with an eye towards the fact that we're all going to be close neighbors very soon and in the same space. So hopefully that will overcome our geography challenges. Yes, hello, my puppy just came back from a walk. So what are we going to do? We're going to talk about why we should engage in interprofessional activity. We're going to do a little reflection. So that will be you guys adding in some of your thoughts. Hi, Cindy. Nice to see you. Then we'll talk about the project that we undertook and how we got there and what were the impacts on the learners and what were some of the lessons that we learned from the process about us as a team and how we can work together. And then what are our future opportunities? So the why of interprofessional education hasn't changed at all. It is still focused on outcomes of patient safety and quality of care, and recognizing if we don't educate our new professionals how to work together in teams. So if they don't meet each other until they get out, and that's the very first time they're having a conversation, that they're unlikely to be able to do that effectively. And the interesting thing is these haven't changed in the literature for 10 years. And it seems like, you know, what we did when these first came out and the first interprofessional competencies came out is there was a lot of interest and work around it. And then it just went off a little bit. And I feel like we have to get re-engaged with why are we doing this and why is this important? And I'll tell you what we learned from our students, I think just reinforces that doing this work is worthwhile, and it is never going to be easy, and that's okay. And we just have to get over that hurdle of doing true interprofessional work. And doing it once a year is probably not enough. That's an exposure versus really embedding it so that all our students on both the healthcare side and the nursing side and the medicine side get to work together. So this is well documented in the literature, has not substantially changed over the last 10 years from the time when the IPAC competencies were published. And Dana, are you thinking anything different to add on the why?
No, I would just agree that I think this is something that when it was first introduced to us kind of officially, I don't think it was anything that was new to anyone, but when it officially came out in the form of competencies, everybody kind of jumped on that bandwagon. What can we do? How can we do it? And recognize that there are a lot of barriers and it can be complicated. and the excitement and enthusiasm for it kind of fizzled a bit. And people took the avenue of, wow, that's really hard. What else can I do that maybe isn't as difficult, that can still expose students to this interprofessional piece of our work in healthcare? But I do think it's the time to re-engage. And I think we learned a lot from this experience from the learner side, from the impact that this really is something that our students are craving and really want to do. And I think it makes it worth the hard work from that perspective. And then from the downstream effects of patient safety and teamwork, but that it's something the students themselves are recognizing as important and beneficial for their education.
Yeah. And I think their voices were very clear around that. Oops, going backwards, not forwards. All right, so we're going to do a little poll everywhere. And the question is, you've been told you have to plan an IPE event. What's the first word that pops into your head? And you can put more than one, and everything is anonymous, and you can put multiple things in. So what specialties, what attendees? Difficult, calendar. What are the, yeah, there's a lot of barriers. What are the objectives? Could be exciting. It's process. So I think these are pretty common worries and things that when we get these kinds of projects and opportunities handed to us. So I would like to pause and hear. So we've got Cindy and any other, just here, and you guys, you can put it in the chat or come off mute and let us know, like, what kinds of interprofessional things have you guys participated in or run? And there you are, Carol Ann, you're back. Just so we get a sense of where you're coming from. IPE for classroom teachers, music therapists, and early childhood music specialists. That's awesome. So it's the education of the teachers in concert with the musical therapists, as well as the early child. Oh, wow, that's great. And then they're all focused on helping the children. So it's allowing them to figure out, well, the goal. Okay, and Cindy saying, yeah, you don't think, yeah, you've had the opportunity to participate, which I think speaks to the fact that we've sort of, it's because of the challenges, I think it's become, you know, it's become less popular. All right, let's get out of here. So one of the things that we did in our SIM committee is we thought we would turn things on their head, and instead of talking about, like, why should we be doing this, the why, the sort of selling the you know, the best things about the car, you know, it's got a great color, it's got good wheels, it's got all these cool things, we thought we would flip it and talk about, well, what are the risks if we as a college, at the College of Nursing and Health Professions, don't participate in interprofessional? Like, what happens? So the team, everybody got an opportunity to participate. And these are some of the things that I thought were really interesting for us to sort of reflect on, because I'm guessing it goes across all professions, is that our learners can potentially graduate without talking to another profession. And we know from our nursing students that is true, because they tell us that this in simulation. I've never had to call a doctor. So they've never had to potentially call to rescue. And that has the downstream effects of, long-term patient safety and patient outcomes. That our learners have a big fear of making mistakes, and they may not even realize that they can get input from other team members that can broaden their perspective or help them be better at their work and improve outcomes. They may have a lack of awareness of what other professions can do because we've never been exposed to what those roles are. So we end up with an incomplete care team, things getting missed, and we're not fully utilizing professions because we don't understand what they do. They might not have an opportunity to practice interprofessional conflict and negotiation. So that means that they're potentially less likely to speak up in real life, which leads to mistakes, which leads to poor outcomes. And they might not be able to fully embrace who they are. So that we were talking about nurse practitioners, nurse anesthesia, advanced practice, and we're not able to communicate what it is that we do in our roles to other professions. And that would impact on new providers not being able to advocate for full practice. And as a university and as a college, then we would not be graduating learners without the basic interprofessional skills. And that means our reputation is diminished. Possibly students wouldn't come to us. We could have loss of tuition. So trying to, this helps us think, why do we need to invest in this? And why do we need to help each other get over these hurdles? Because these are pretty big risks that our students can graduate without communication skills with other professionals. They have increased liability, which has personal and professional impact. And if our graduates don't feel comfortable in their new professional role, that they have an increased risk of burnout, moral distress, and leaving the profession. And those to me are really profound things that nobody wants for their new profession, health or education or other. So it is worth doing, as Dana says, the amount of work and collaboration and rethink that is needed to get interprofessional activities off the ground. So we're going to talk about what it is that we did to give an exemplar. So Dana, I'm going to hand it over to you because you came to us and said, hey.
Yeah. So I'm definitely one of those people that is more than happy. We were talking about how sometimes now students don't talk to others and won't talk to strangers. I'm more than happy coming to talk to strangers, to ask them to play in the sandbox with me. Luckily, I have known Kate for a long time and have done interprofessional work with her. So reached out from the College of Medicine because we also have competencies that are required for interprofessional education in our medical school curriculum. And we have had some experiences, but we've always been challenged to integrate with the College of Nursing and Health Professions. And I think we've always thought about it as, the calendars don't mesh, the times don't mesh, it just doesn't work. But we came to a realization that we can work around that, and that recognition of the importance of these experiences from the learner perspective outweigh the work and the complications that can sometimes come with it. And when you do have a team, I think that is invested in the idea and engaged and does recognize that importance, that work that we think about isn't as difficult as it may seem at the outset. Mm-hmm. You learn to think creatively. We created a really large team, I would say, of people. It started out small, it grew. We brought in the simulation, the whole team, to get their input onto how to make things work from a logistical perspective. So bringing in as many people as possible is really going to help make the planning easier. The more thoughts you have in the room, the more likely you're going to find ones that stick and work for everyone.
So Dana, you were running your course. So tell us a little bit about your course and sort of the genesis of how we put it together with undergrad nursing.
Right. So as part of we have a senior boot camp in the College of Medicine for students once they've matched into residency, to prep them for moving on into their internship and residency. And in my review of that curriculum and what they were doing, I found that one thing that was missing was that opportunity to practice communication skills with nursing. It is one of the most common things a new intern does, is takes calls from nurses and makes calls to nurses. And it was something that our students did not have a lot of opportunity to do. They talked to nurses, but they were more relaying information from the team, not so much having that actual conversation with them. So I came to the College of Nursing seeking help, and asking that we partner together to allow for the medical students an opportunity to receive calls from nurses and field those calls, and how are they going to connect and communicate with them. And then from the nursing side, the same thing, giving those nursing students an opportunity to practice the skills of calling, as well as being called by a provider. On the nursing side, we had the barrier of our 2-week course is calendared into the year. It's actually the only course in our 4th year that is calendared at a specific time. And it happened to fall on the College of Nursing week of finals, and week of spring break. So, I mean, if you want to talk about challenges in calendaring, I don't think you can get more challenging than that. And I think one of the, Kate will talk about how the recruitment happened, but I think one of the things that I look back on is how phenomenal it was that we had students who volunteered to come do this on their spring break. We had new graduates who volunteered to come do this on their spring break. So I think that demonstrates how important these students felt that it was that they have an opportunity to practice, that they took, their own time to be able to come do this, not just to help the students, but I think they recognized it was going to be helpful for them as well. So from my side, recruitment was easy. It was a mandatory class. I could tell the students they had to do it. The nursing side had a little bit more of a challenge ahead of them. So I'll let Kate talk a little bit about how we got the volunteers signed up.
Absolutely. So this is where Megan Chaddock and Jen Pareca did a yeoman's job. So we do have an SBAR activity that goes on in Meg's 3rd year nursing course. And it had been done online. And this was in an online environment because we were still in the throngs of COVID. So we were doing this online, also during break week and exam week, and recognizing everybody's level of fatigue. And yet we knew that this was a common problem for us. And we had heard in simulations that people were time and time again said, I never get to call. The nurse always calls because it's an urgent situation. And we know that they tend to get hip checked a little bit out of the way, all in good intentions, but they don't actually get to practice it. So the call went out from Megan to all her students in the class who were graduating. And then we also targeted people who had just graduated. And then we moved it out and targeted people who had graduated within the last year. And it was, I think, really interesting that we had a number of our alumni come back and do it. And their feedback, when we get to feedback, but they were like, this is awesome. I wish we had done this while I was a student, because now they had to have made those calls as a new grad, and they had the opportunity to see how meaningful it was going to be. So part of the recruitment too was making sure that everybody was comfortable, and we gave some structure to what they were going to do. So they knew what they were signing up for. So they were going to come into a Zoom room. They were going to work in a team. So there was usually 2 nurses to 1 physician. And they knew what their cases were going to be. And they had 3 cases that they were going to work through. And we wanted them to see an example of what SBAR, which is situation, background, assessment, and recommendations, which is a way of structuring a conversation. And I'm going to just sneak out of this and take you to YouTube to see the beginning of the video that was made in order to share information with the nursing students. To A, it was a recruitment tool, and B, it helped them get prepared. And we're not going to see, and you guys can follow this link and you'll get all the slides from Darren at the end. But you can see there was an ineffective and an effective, and then a little bit around peer feedback.
Hi, Megan. Good morning. You paged me. What's going on?
Oh yeah, thank you. Thanks for coming down. I was actually waiting for your phone call back. So I'm calling about Mr. Smith in room 2.
Okay.
Concerned about this patient because I had the CNA go in and do a set of vital signs on the patient, and the pulse ox is low. So
Okay.
patient's pulse ox is only about 88% right now. So I think we need to go in and see the patient. This patient was admitted last evening. I did admit this patient last evening with congestive heart failure exacerbation. And previously the patient does have a history of CHF. Patient told me he's been off his medication for the past couple of days and his diet was not as well at home as it should be. So eating a lot more sodium, not really following those fluid restrictions. So it sounds to me like he's struggling to breathe just a little bit. What do you think we need to do?
Well, I have a couple of questions for you. Do we have any labs?
Yes, labs were drawn. I haven't been able to find them just yet because they just upgraded the system. So
that's a little red flag, not such a good answer.
I haven't been able to find the labs yet.
Okay. And other than pulse ox, do we have a full set of vital signs?
No, I haven't actually had a chance to assess the patient because the shift just started, but I know the pulse ox was low. Night shift nurse said vital signs were stable all night. Every now and then pressure would.
So I'm going to pause there and you can watch the whole thing. So there's an example of effective and feedback. So you can see, so the learner, the nursing students and the recent graduates could sort of see like, where are the pitfalls in this one? So they knew exactly sort of what was the buff to help people get better and to make some examples. So they understood what was going to come for them, which is important when you're signing up for stuff. So let's just go back to the how. Yes, go ahead.
He brings that up for the medical student side. As part of our course, we actually had a session with the students on SBAR. We do teach them SBAR before they go into their clinical years, but we had an SBAR refresher for them prior to this activity, just to kind of prime them up again for how you have these conversations. They were also provided the cases in advance, so they had an idea of what they were going to be talking about. We didn't want anyone to feel off guard or uncomfortable with the content, so that we could really focus on the communication side of things.
And the a lot of the literature around simulation now is asking the question of, are the learners ready to be in the whatever learning thing you're going to do? So all of that work is readiness. So people are coming in ready to apply, ready to try, ready to make mistakes and learn from those mistakes. So part of what we did was the logistics in the virtual space, and we had gained a fair amount of expertise out of necessity of what could we do in the virtual space? How could we run this number of rooms and move people around? So we met with faculty and all our simulation operations team to figure out like how could we structure this? How could we move people so they would have different experiences, making sure that everybody was in the right room with the right people at the right amount of time, and then they got moved out and then more people came in, and that's like, they were amazing to help us think through all those hurdles. Zoom allowed us to do that because we had unlimited numbers of breakout rooms, and they managed mapping everybody so that everybody was mapped with the right people and getting the right people in the right rooms, which is, you can imagine when you have in your waiting room like 150 people and you're trying to figure out, is that doctor, nurse, that they really, it's quite a remarkable feat. And that took multiple meetings and huddles to figure out, because we would think we had the answer and then someone would be like, oh no, wait a minute, that's not going to work because X. And we would meet again and huddle again about, all right, let's make sure we all understand what we're doing. Do we have the right model going in? Does anybody have any concerns? And inviting, speaking up, and solving problems ahead of time. And I think also agreeing that, look, if things don't go exactly as planned the day of, like how are we going to respond? So we sort of had a triage of, hey, if we get people in the wrong room, what are we going to do? If we lose somebody, what are we going to do? If we have technical problems, what are we going to do? So we had worked through that process, which I think reduces everybody's stress of running the event, because you have a plan if things go wrong. So it's not so, you're not so worried about things going wrong. And you have a shared agreement of problem solving the system versus, feeling like one misstep is going to ruin your whole event, because it's not. And these guys are going to work in a complex system that has errors every day. So helping us model for them when things don't go so well, how do we respond, we thought was important. We also agreed that as facilitators, and this was, I think a little bit more challenging for some of us, is that we were not the primary teachers here. The peers were the primary teachers. They gave feedback to each other, and we'll show you, we gave them, some guidelines around feedback and a proposed easy model. But in many of these rooms, they were on their own. And sometimes we were in there as a nurse or as a doctor, just so that we could make up the numbers. But I think that actually enabled them to have much better peer-to-peer conversations. But it was hard because, you want to be the one, like, we're faculty, we have to be the one that teaches them. And the answer is we don't. And they did a really, really good job of teaching and supporting one another. And that also we didn't have to have, like, we would have never gotten, I don't know, Dana, we would have had to have what, 25, 30 faculty?
At least, yeah. So just to give you guys an idea of the numbers, we have 265 graduating med students a year. So that was just from the med student side, and then partnered with all of the nurses. So had we even thought about having facilitators, one, we couldn't have facilitators for each individual group. There's no way we would hit those numbers. But I think a lot of times the number of facilitators is a huge hurdle for us, whether it's in person or online. And then training those facilitators, and it's a whole nother set of issues and needs and work to be done for an event like this to happen. So I think, like Kate had mentioned, I just want to reiterate, partnering with the whole simulation team was huge. I think another thing that we often do as faculty when we're creating experiences is we as faculty get together and sit there and plan this out, and this is how it's going to go, and this is how we envision it, and we have it all set in our heads, and then we talk to the team that's going to help us run it, and they find 15 holes in the plan that really could have been thwarted had they been part of the initial meeting and saved everyone a whole lot of time. So I do think it's really important to get together, not only with the educators that are trying to plan the experience, but those who will be logistically helping you run it, because they are going to have totally different perspective and insight than what you may have as to what can work in whatever platform you're using.
Yeah. A critical piece. I totally agree. And then in developing the cases, and this, is not unique to healthcare. I think what we learned is it doesn't have to be that complex. And oftentimes we think it has to be that difficult, when really the learners are trying to learn a skill. They don't need all that additional cognitive load. They just need an opportunity and enough information to practice the skill that we're focusing on. And in this case, it was a structured way of communicating patient handoffs. So we went back and we streamlined the cases so that they were much more straightforward as time went on. And I think that also helped us, and it helped the learners because they didn't get stuck in the medicine. They stayed in the conversation, which was what we were hoping for. We talked about the prep for the nursing students, and Dana talked about the prep for the medical students. I think my next slide is the feedback. Nope, not yet. Okay. The flexibility in planning. so this really, I really do think we were about on plan E, because we thought we would have more people come. And so we had to sort of think down through, well, who else, what are our other populations that would be interested in doing this? What are the other things that can help people want to do this? Megan and Jen created a little certificate of, you participated in this educational experience for their CVs, which would be helpful for our new graduates, but it required us to go back to the well multiple times. And I think why it worked was we were all like, okay, well, what else can we do? What are our other opportunities versus, this is too hard and we're not going to be able to do it, is just recognizing. And one of the things is that not everybody is going to have the exact same experience. So not every nursing student is going to be able to do this, and that's okay. So those that want to volunteer, that's wonderful. And we're hoping word of mouth, and they'll tell their friends and so on and so forth. But I think that let us feel like, okay, well, we are going to do our best to recruit from our current class. And we wanted them to have enough experience to feel comfortable in the space. So we couldn't go back to the, very new undergraduate nursing students because they weren't ready to be in this simulation of learning. Dana, what else to add around flexibility?
I mean, I think flexibility is huge in interprofessional education and collaboration. And I think it's, there are going to be roadblocks, there are going to be stumbles, recognizing that in general, it's never going to go completely as planned, and just accepting that and being okay with it. And I think, we tried to demonstrate for the students, as Kate mentioned, how we handle when things don't go exactly as planned. And we then could also role model that, flexibility is a great thing to have. And again, it allowed for opportunities and ideas to come up that we didn't think of in, our first iteration of planning, that turned out to work really well. For example, we had the sim ops team actually created like an introductory video for this event. We were all sitting there planning who's going to introduce it every time. We'll take turns, we'll do this, who's going to do this. And they're like, we're just going to make a video and play it, and they're going to all get the same introductory video. I was like, that's genius. Like, never would that have occurred to me ever to do that. And then also recognizing, like Kate said, we tell the medical students all the time when they go into clinical sessions that your experience will never be identical to another student. Even the student who is sitting next to you on the same rotation at the same place will not have an identical experience. You're going to see different patients, you're going to talk with different providers. So coming into simulation with that same understanding that we can't guarantee that every student is going to have the same experience, but we can pretty comfortably acknowledge that you'll achieve the same goals and objectives at the end of the experience. So recognizing that, that is our goal for the experience, not so much making it identical for everyone.
Yeah. We thought a lot about peer feedback, and what we did is we kept it very simple, and we made a suggestion, and this was sent out to all the students ahead of time, that they could use this to structure their peer feedback. So they did their case, then they paused and gave feedback to each other, and then they would switch and do another iteration of the next case. And they each had 3 cases. So everybody had an opportunity to be in the conversation, and everybody had opportunity to be observing the conversation. So we suggested that this was the framework. We talked about the basic assumption that everyone is intelligent, capable, cares about what they're doing and wants to improve, and to approach their conversations in terms of giving feedback to each other from that standpoint, because it was unlikely that they were all going to be fantastic. You know, there will be bumps in the road, or there'd be information that wasn't shared. And they did have their cases, and it was a physician. So there was a nurse calling with a problem. Then there was a physician calling the nurse to give labs. And then the nurse was calling for follow-up and a family issue. So there was two different perspectives of the calls, which I think were also helpful. And from the ones that I was in as a participant and helping round out the team, I would say that they did a variation of a theme on this, and they gave substantially valuable feedback. Like, it wasn't just, hey, great job, but they were very specific about what worked for them and what didn't work for them, which I think is so helpful for all of us as we're trying to hone our skills. So I think this actually worked, even though, and we did not do a big presentation on peer feedback. We did not, but we were thoughtful about going through a bunch of different models to try and get something that was simple, accessible, and level across the two professions. It seemed to work. So what was the impact and the learners' feedbacks? So by and large, everybody enjoyed the ability to practice using this structured model of feedback or of conversation and get feedback. And they really thought it helped understand each other's thought process and role. So a lot of times they realized they were coming at the same problem from two very different ways, and at times speaking slightly different languages. So it helped them understand that, which is a big challenge of how we communicate at times. It instilled confidence that they were more likely to pick up the phone and call a provider in the future. And our new grads had wished that they had done it earlier. And learning to trust learners to give and get feedback, that they can actually we know that peer and near peer feedback is oftentimes received better than instructor, educator to learner feedback. And then do you want to pick up Dana, the medicine side?
So from the medicine perspective, obviously the students were thrilled to have the opportunity to practice a skill that they knew and recognized would be used commonly. I think everybody appreciates when they get to practice something that they know they will be putting to use, rather than practice something that they may use in the future. So I think they all recognize that. And that, that communication, I think they learned as much from the experience of actually doing it as the feedback experience. I think, they acknowledged that getting the feedback from the nurses as to how they communicate it, let them understand a little bit about, how to just have open conversations, and how if somebody's questioning you, it's coming from that perspective of curiosity and understanding, and not in a defensive way. So I think it really did help them to go through the actual skill of doing it, as well as understanding the communication process better. Mm-hmm. And I think from our side as faculty, we learned a lot as well. It had impact on us as well, that, we did let go a lot. As Kate mentioned, we usually try to have facilitators in everything, so that, we feel that we know that they're getting what they need in that respect. So we took a step back, and we let the learners give and get the feedback, and we got good feedback about that. The students enjoyed hearing from each other rather than from us. We learned that keeping it simple is really key, especially when trying to focus on communication skills. You don't want to see students get bogged down in the medicine or the case, or trying to understand what's happening. You really want them to just be able to focus on the communication itself. And then I will say we couldn't totally let all of the feedback go to the learners. So we did, at the end of each session, gave our faculty pearls. So things that we as the faculty thought should be takeaways for the students. So we called them our pearls to add to your string at the end of each session, so that, you know, we knew that we at least put it in their heads. You know, here are some of the key points that you should have taken away from this experience. But I think most of them had that in their small groups as well.
Mhm. And they did share a lot of their own take homes before we did as well. So it wasn't, just us
Yeah.
saying at the end, and this is what we wanted you to learn, which is so hard not to do. But I do think the global, you know, I'm remembering the picture of like all the learners on the screen in our Zoom when we would have at the end of like 40 or 50 of them, and we would do, and they were in the chat and sort of sharing their different perspectives, which I think was really important. So to highlight the big things that I think made this possible was the Dana's concept that it's comparable, not identical experiences, I think freed us up to find other people who could participate and recognize that it's okay that not every single student in a particular course had this particular opportunity, and that it is okay that if things are a little messy, because life is a little messy. And we all agreed that there were going to be lots of mistakes along the road, and we were going to approach them as opportunities for learning and figuring out, you know, how do we be deliberately developmental and just keep getting better. Flexibility and frequent huddles with the team so that we weren't living in assumptions. Like, I assume Kate knows this, I assume Dana knows this, I assume this is what we're doing, which it allowed us to sort of clarify those things and make sure we had a shared model. And then partnering with your operations team to help you with these large events early and often. And they were involved the whole way. They were at every huddle. They led us in many of those huddles to solve our problems. And really important because, as Dana said, they have a different perspective. So our question to you is sort of thinking about how you can engage in interprofessional education. And Carol Ann, I'm dying to hear how you do it with educators, musical therapists. So if it's possible, I'd love to have you share how you do that.
So early childhood music specialists and music therapists are often interfacing with care staff and clinical staff outside of our profession, and also classroom teachers. And the situation I'm most familiar with is classroom teachers. And if we're working with students in a particular classroom, how do you help the classroom teachers understand what's happening in the room, and how do you understand what the teacher's expectations are? So it is same kids, but you're coming at it from two different perspectives, which is very much analogous to the nurse-doctor relationship that you studied. It's tricky. It's really tricky because music therapists and music specialists, we talk from trying to explain what musically we're doing to get what we think the teacher's educational or learning objectives are. Mm-hmm. And music therapists to music specialists, there's a lot more overlap, but the goal for these two different professions is very different. In clinical work, we are looking at often a non-musical outcome. But in early childhood music education, we're looking at the music development of the child. So they could be dysregulated, but look, they're keeping a beat. Mm-hmm. Or great, they're keeping a beat, but they're climbing on the ceiling. So how is this helpful? So so we're looking at it from two very different ways. And the poor classroom teacher's like, could you just make sure that I have the right words to write down in my lesson plan so I can show that I've done the things that we're doing? And then how do I make this happen when you're not here is the whole other thing. Mm-hmm. And where we find the most success with the classroom integration is exactly what you said, by having all the players in the room at the same time and having that opportunity to hash through made up scenarios that we can then give each other feedback on. And that's so important to be able to do, preferably early on in the relationship between the classroom teacher and the music person, because that sets up the whole tenor of the whole academic year.
Right.
And the interesting thing about your situation is that is not the same in mine, is that yours is ongoing throughout the whole professional, however long you work there, however long you're rounding there. In our situation, it's usually limited to a 10-month academic year. So it could be a great academic year because you've gotten off on a great foot, or you could be slogging your way through and just waiting until, excuse me, my family's loud.
That's okay.
Waiting until May or June till the whole thing is over, please. So, and I very much, right now I'm in a small study. I'm a research assistant for a small study out, not through Drexel, but through another organization, looking at, part of it is this exact relationship with the classroom teachers and paraprofessionals and the music therapists. And we're finding that we have to pay more attention to this.
Yeah, it's not something that develops organically for everybody.
Yeah.
And I think the idea that we have to be deliberate around developing these relationships, taking other people's perspectives, being able to listen to another perspective. And I just think it's so fascinating that it's the same challenge in medicine, because, nursing has their language, medicine has their language, therapy has their language. And if we don't have common language of outcome and what we're trying to achieve, then we're not listening and helping and leveraging each other. And it sounds like it's a lot of the same piece. And I love that it's like almost like this sets the tenor for how you work together for the academic year. So having simulations to set the tenor. So wouldn't it be fabulous if we had simulations in a team, an ad hoc team that has to work together? So Dana, I'm thinking about, like, now we do huddles in the hospital, right? And that's part of almost like, who's on the team today? How are we going to work together? What are we going to do if, something terrible happens or we have 4 deliveries all at the same time? And those little bites, like, it doesn't have to be everybody in the pool all at the same time. That takes every resource you have. And I love that we did like that little bite with you. And now how can we get another one and another one and another one with all our other colleagues? We have musical therapists in our health sciences program. Like, how do we just need to get started. We have to do something. Doing nothing is not the option, I don't think. So Dana, I know Interprofessional falls under you. So what are some of the ways you're thinking of spending more quality time with us?
Yeah, so, I have so many thoughts. And it's really exciting to me. So we just did an interprofessional panel yesterday, actually, for our rising 3rd-year students, so about to enter clinicals. And we had representation from 4 different disciplines, but I had multiple students come up to me afterwards and say, can we get a dietitian on this? Did you know there's music therapy? Did you know that? Yes, I know there's 900 other kind of health professionals out there. I unfortunately can't get them all in this room right now in this moment at this time. But, I think what it demonstrates to me is like our students are craving to learn more about what other health professions are out there and how can they use them, because I don't think they have a great understanding of what all of the roles are. They think of a dietitian and they think, oh, they're going to talk about, the diabetic diet or a low salt diet. And then when they dive in a little bit more and see all of the things a registered dietitian can do, they're like, wow, they have the same response to PT and OT and, each profession they learn about. So I'm happy to provide students for all kinds of interprofessional experiences. From basics, just letting them giving them the opportunity to get to know the different professions and specialties and roles and what's out there, to engaging in conversations, to doing care together, through simulation. And I think we can work together to break down some of those barriers. Soon our geography will be closer together. I think a lot of our goals already align. It's just working through the process, and finding champions in each of the disciplines that are willing to engage and put in a little bit of work, but to have, I think, a great satisfaction at the end of it, in seeing the impact it has on learners.
And Cindy, I'm thinking, having some of the medical students come to class. So we are doing reverse panels of both directions. Like there's just so much opportunity, and we all live online now. So if it's some of our online learners that are in online programs to be able to come in and share their different perspectives, I think also works. And I feel is like incredibly freeing of not everybody has to have exactly the same, but we have to have similar outcomes. So I'm hoping that that's going to help us be able to get over the hump of it feels very weighty, and we don't have to do everything in a day, and we can do little bits, and we can be diverse. Like it doesn't. Go ahead, Cindy.
I was excited to come to the presentation today because about, I guess, 2 years ago, with Kate's help, for my dissertation study, I created a series of 3 simulations for novice nursing students. These are students that are in their fundamentals of nursing course. And they had 3 scenarios. The first one was they went in and they met their patient, and the patient had come in with a diagnosis of congestive heart failure. And they went in, and the lady says to them, she's sitting in the chair, I feel dizzy. So they have to check their vital signs because that's where they're at in the whole learning curve. So they check their vital signs, and the lady has a low blood pressure. And then the next thing that they have to do is they have to call the physician. So we had a standardized participant play the physician in the scenario. And they just basically, because they were in fundamentals, so they just had to call, learn how to introduce themselves, and communicate what the issue was with the patient. And it was a great learning experience because some of the students would call right away without getting the vital signs, and then the standardized participant would say, well, what's the blood pressure? Or what is, oh, I haven't got that yet, I'll come back. Things like that. So I think it's really helpful. And I always thought after doing that it would be great if we could have, medical students be the physician, have the physician role rather than standardized participants. It went very well, but I thought that would be a great way of working together interprofessionally. So just similar to what you did for your program. And the students really appreciated it because they were in fundamentals. So they had no idea how to call anyone. And so it was really a great experience. And I always thought, gee, it would be great to have medical students portray the physician in the scenario. Not that the standardized participants weren't great, but I thought that would be a great way to kind of get the specialties together, because like what you had mentioned and what you found in your experience was that they don't feel comfortable doing that. So I kind of felt like if we start this at the beginning of their nursing education and scaffold this as they go along, hopefully, when they finish, they will feel more comfortable communicating and actually the goal was to make a sound clinical judgment, because that's one of the major issues when nursing students graduate. They have difficulty making a sound clinical judgment. So my thought was, and what I had read in the literature as well, is it would be great to have it throughout the program. So I'm excited to see if maybe we can, work together in the future, because I think it would be great.
I also think as you're talking, Cindy, thinking about, we used to think that people had to know what their own role was, like have role identity before they participated in interprofessional, like, because how could I tell you what a nurse is if I don't know what a nurse is? And I'm not sure that's really true anymore. Like, I think they can do some of that exploration with guidance of like, what does it mean to be a musical therapist versus a physical therapist versus, a nurse. And I think they can do some of that exploration with guided support as needed. So I do think you can do it much earlier on, whereas I used to think it just had to be after they had figured out like who they are a little bit. And that was the earlier literature in IPE. And I think we missed an opportunity potentially. So I'm hopeful that we have shown we can do it online, so we can certainly do it in person. And our geography will be very nice because we'll all be in the same space at the end of 2023, which will give us, Dana, we have a year and change to be like planning and meeting with people. So thank you for coming. And I think with that we'll end. And I do want to say again, our colleagues, Megan Shattuck and Jen Pareca were, and our SimOps team were critical in the success, and they were, unfortunately not able to be here today, but they contributed to the design of the talk, to the design and the implementation, and we're very grateful for them. And Darren, I see you're back on screen.
I am. Thank you so much. That was really an interesting conversation. It was nice to I always love it when people dive into the weeds about how they worked out a problem. That's always great. All right. Well, thank you for joining us, and we'll see you at next week's Tuesday topic.
All right.
Thanks,
Darren.
Thank you.